Thank you very much, Anya. That is, thank you very nice for your nice introduction. And I start immediately sharing my slides.
Great.
I believe that's the right. Can you see
Yeah, we can see it.
a full screen?
Full screen, yes.
Excellent. So we
Thank you.
started properly. And I wanted just to say that it's really a pleasure to have the opportunity to meet young investigators in the European Society and in the framework of the TOTSLearn project. And I'm also very glad to have the opportunity to talk about biomarkers or early effect. This is something that I believe is, it's obviously was one of the main focus of my research, but is also something that I believe is extremely important for anybody that wants to start a career in toxicology or in genetic toxicology, but also for anybody working with different branch that can be applied to human studies and not only human studies. However, let's talk about early effect biomarkers. The idea of early effect biomarkers is like 40 years old, maybe a little more. The general idea is that there are kind of biomarkers that are surely associated with the exposure because they are the direct consequences of exposure, but in a way they anticipate the disease. So if you look at this very old graphic, that was a historical one, I would say. That was the first one placing the early biological effect really in the middle of the continuum between exposure, I would say the genetically favorable environment, so the combination of exposure, this genetic combination, start the continuum that in a way as a critical issue, a critical step in the middle. People at that time was very excited by the idea of anticipating the disease, to have a sort of in what was called intermediate endpoint of disease. And actually, there are some critical studies at the very beginning talking about intermediate endpoint for cancer in this case, that can explain fully the disease. But that in a way was a sort of dream because biology is much more complicated. Actually, there are different endpoints, intermediate endpoints, which are in the middle in the pathway to disease. And then even more complicated is the situation in which we have different exposure that may activate or not different intermediate endpoints. And all of them bring to the disease. So that means things are much more complicated than we expected. And just to have an idea, a quantitative idea of this complication, there was a seminal paper that was published by Shatskin in the 90s, in which he tried to make a quantitative estimation of the contribution of different intermediate endpoints to a disease. And he said, okay, we should understand how important is an intermediate endpoint for one disease, depending upon the attributable proportion. So attributable proportion is the proportion of the disease, the part or the etiology of the disease, which is explained by that specific intermediate endpoints. And just to have an idea, this table put together the sensitivity of the intermediate endpoint. When I say sensitivity, you know, screening, sensitivity, specificity. I mean, generally in screening tests, they are quite high, 90% or so on, which is the proportion of cases of the disease which are positive for the intermediate endpoints. And so this is go from 10% to 9%. In this line, instead, we see the relative risk. I mean, what's the risk to develop the disease once you are positive to the intermediate endpoint. So you put together the two things, and you see that, for instance, if you are, let's say, a risk of maybe 10, which means if you have the positive endpoints, like think about micronuclei, since I will talk mostly about that. If you have a very high level of micronuclei, you have, this is hypothetical, you have 10 times more risk. So we are in this column, in the last columns. If the sensitivity is also very high, 90%, it means that 80% of the disease, let's say cancer or whatever, is explained by micronuclei. That would be great, because we could do a lot on that. But this is not real, because generally we have a sensitivity which is about maybe 10 to 20 to 30% maximum, and the relative risk is about 2-3 times. So we can assume that the biomarkers of genomic instability that we generally use may be around explaining 10-20% of the disease that we are studying. So that means that the idea is quite complex. And actually, I want to make a jump now from 1990 to yesterday, and just to report a project that is going on by OECD, in which they started, they started to say that the effect biomarkers are highly underused. So that's good for us. The second is that maybe that we cannot just stay on a single endpoint, but we should consider what is called an adverse outcome pathway. So because a pathway, the idea of recognizing the pathway bringing to the disease in which there are different biomarkers of effect. So that makes the things a little more complicated, but closer to the real world. And this is extremely interesting. This is also interesting, the point that they make, in which to say that endpoint in effect biomarkers are very important to measuring the effect of mixtures. And this is real, because in real life, it's very difficult that we find the population exposed to a single chemical, to a single genotoxic exposure. And one of the the results of this study was just to represent. You remember that the previous continuum of events from exposure to disease, and now they are much more complicated. And the idea is that we have an adverse outcome pathway that is in a way is synthesized in this part of the flow. But I didn't want to focus on that. Rather, I want to talk to you about another part of that study that was done by OECD, in which they provided a very interesting inventory of what could be the biomarkers of effect. And the application, the possibility of this biomarker are really extensive, and they can jump from cardiovascular biomarkers, cardiovascular diseases, serum lipids. Obviously, anthropometric biomarkers can validated like that, hepatic, renal, and so on, reproductive, thyroid, genotoxicity biomarkers. So the idea is that there are several fields for biomarkers of effect to take place, to be relevant for research. And they did a very interesting table in which all of these different conditions are reported, and the related health outcomes are reported. What are the effect biomarkers? What are the kind of exposure that can be used for, and what are the strengths and limitations of the application of effect biomarkers in these fields? And I just took a couple of them. Serum lipids, for instance, are marker for atherosclerosis and metabolic syndrome. And there are like low density lipoprotein, different fraction of total cholesterol, and total cholesterol, of course, but also adipose biomarkers of adipose tissue functions. And what are the chemicals for which they are relevant? Maybe there are several. Most of them are endocrine disruptor, and there are a number of strengths and a number of limitations. For instance, the use of cholesterol, the extensive use of cholesterol, that means that we know a lot. That is a strength. The low sensitivity, for instance, you cannot use it in children, and are a kind of limitation of this assay. Well, why don't we use effect biomarkers to predict diseases? We know a lot, so there is a lot of strengths for using that, but there is also a number of critical limitations that mostly explain the reason for which. So nowadays we cannot use these biomarkers in clinics or for perfect risk assessment. One is that there is a gap in between the effect that we measure and the disease. In some cases, may be a very long gap. Think about cancer, maybe like 20, 40, 30 years. And furthermore, there are technical heterogeneity. For instance, we published recently a paper on the COMET assay. We see that the measurements of the contents of DNA is very variable in different laboratories, and even within the same laboratory with different scorer. The other point is that there are intra-individual variation. People can have different measurements of damage in different periods of the life. And then there is also there is a number of heterogeneity, biological and technical heterogeneity that combine to the length, to the gap between the measurement and the disease, limit the use of biomarkers of effect. Then what to do? So one of the answers is to validate these biomarkers. So because once we have validated biomarkers, so we know exactly what are the association, what is the strength of the association between the biomarker and the disease. And to do that, we have to go through a process of validation. We published this year or last year, 2 years ago, together with Mike Fenech, a proposal that was specially focused on micronuclei, but is absolutely applicable for all early effect biomarkers. That is the idea. We start from the mechanism linking the biomarker to the disease. Then we should understand, find that the biomarkers is different. The frequency of biomarkers is different in between people healthy and people with a disease. And then we have to see if this biomarkers is valid at individual level. And the studies that are more relevant for the validation process are the prospective studies, the control trial, and the clinical trials in a way. And the pragmatic trials, which means also not only in clinical trials, but also in real life. Then obviously there are the clinical use that can further validate these biomarkers. Let's talk a little about the biomarkers that I used just to make some example. You know probably everything about micronuclei. I don't have to say more about that, just which is a marker of chromosome damage, chromosome instability, but also considering the cytome assay, which is different endpoints that can be measured together with the micronuclei presence. We have can be an index of genomic instability, DNA damage, oxidative stress, and so on, and necrosis, apoptosis, and so on. Then there is a number of endpoints in the same assay. And what is really important is that we can measure the frequency of chromosomal breaks and rearrangements, which is an etiologically important issue for many diseases affected by chromosomal instability, but also the fragmentation of chromosomes can activate some pathways in the cytokine activation, in particular the CDAS STING induced inflammation. Then it's quite clear that there is a role of micronuclei also in the etiology of diseases driven mainly by inflammation. So in a way, we are happy with the first step of validation. So there is a lot of mechanistic evidence that would link micronuclei formation to a number of different diseases, cancer, but also many other diseases. What are these other diseases? We published this paper in this book. Was actually a chapter of a book in which we say, wow, from the literature, there is a number of diseases which have been associated with a higher frequency of micronuclei, which is to say, to genomic instability, DNA damage, oxidative stress, inflammation. Then we found a higher level of micronuclei in aging, for sure. Then infertility, pregnancy complication, diabetes, kidney, a number of cancer, and some neurological disorder. So also this second point has been demonstrated in a way. And then we try to focus a little more and to define a little better the association of micronuclei diseases with a special issue that we also published again a couple of years ago, in which we, together with many people that are also involved in the project, and some of them are present now, right now. And in the main paper describing the result of the special issue, we summarized, and we reported as many diseases, including coronary artery disease, chronic diseases, diabetes, obesity, so on, were non-cancer diseases were associated with micronuclei. You see that people with high level of micronuclei showed like 4 times more risk of diabetes, 3 times more risk of coronary heart disease, 2 times more risk of kidney disease, which is quite interesting, which is getting closer to a clinical relevance. Also, obviously, many cancers were associated with micronuclei formation, but especially blood cancer, since micronuclei are measured in lymphocytes. This association is true for lymphocytes, but also many cases were demonstrated even better association when exfoliated buccal cells, micronuclei measured in exfoliated buccal cells were measured. You see that the mean ratio, which is the relative risk in a way, corresponded to relative risk of oral cancer, were 10 times higher in people with high frequency of micronuclei in buccal cells. However, you remember that I told you that the critical step for validation is the step number 3. Which is prospective studies and randomized controlled trials. We don't have yet randomized controlled trial, which could be the real proof, but we have initial results from prospective studies, which are really important. This is the result of a cohort study, an international study, which was published quite long ago, but it was quite important. It's got about 1,000 citations, and in a way demonstrated or supported the idea that people when they are healthy but they have a high level of micronuclei, they have a worse survival. So higher probability of getting a cancer, a lower probability of survival. You see here that survival curve as people in the lower tertile of micronuclei frequency has a much better probability of surviving. I talked about micronuclei, but this is not the only one. I took just a couple from the literature. For instance, cytotoxic activity of peripheral blood lymphocytes you see here are associated with a higher risk, a higher incidence rate of cancer, all cancers. That also, even interesting is negative studies. You see that total cholesterol was associated with cardiovascular mortality for a long time, but nowadays it was quite clear that total cholesterol was the very first results were biased in a way, because were concentrated on people with already had cardiovascular problems. And also the idea of that high level HDL and LDL subfraction of total cholesterol may be much more predictive. But however, I like more this this graph that was based on 12 million people in Korea, in which they found that the probability was pretty low in the people with 200, 220 cholesterol, milligram of cholesterol, which is considered a high risk area traditionally. So that means that cohort study can tell us a lot. Validation, we have some example of fully validated biomarkers, micronuclei in this case? And yes and no, because it's validated for radiation biodosimetry, in occupational monitoring, for the deficiency of folate, spleen function. But obviously, when we look into the more important chronic diseases, you see that we have still to do something. And so aging, cancer, cardiovascular diseases, chromosome frailty, and so on, we have a lot of evidence, but possibly not enough to use it in clinics or for prevention. However, I talked right now mostly about the prediction of the disease. So the idea was mostly linked to the idea of a human prevention, occupational and environmental preventive intervention, in which we anticipate the cancer, anticipate the disease, and we make a prediction. So that was mostly based on research and occupational and environmental research. Clinics is something more in a way, or something more extensive. And you see that still there is a bridge in between research and clinics. And when you look into clinics, there are so many possible applications of biomarkers of effect. Can be used not only for prevention, but also for diagnosis, as a therapeutic target. Can measure adverse events in randomized controlled trials, can contribute to the genetic profiling and to the personalized medicine, can measure the efficacy of rehabilitation, can be used as a surrogate endpoint in randomized clinical trial, important for the prognosis, quality of life, etc. Well, give you a couple of examples. And for instance, we have been working together with people in Coruña, Blanca Lafon, Vanessa Valdiglesias, in publishing paper. I mean, they are the good ones. They publish a lot of paper, and they are very important and internationally recognized expert now in frailty. We published together some papers on micronuclei. And the point is that in frailty, which is a condition extremely important to recognize because it can anticipate the risk of mortality, the risk of disability, the risk of, I told you, mortality and disability, essentially. And we have frail people, also pre-frail conditions that can be used to prevent the progression to frailty. Nowadays, frailty is based on clinical factors. And so the idea, micronuclei have been found in many studies to be increased in people with the frailty. So nowadays there are going on studies to see if we can join the genomic instability to clinical events, to clinical markers. Clinical markers are like if you can, how long you can walk, if you have lost weight, if you the strength of your hand grip, and other clinical practical markers. But can we use also molecular biomarkers? That would be great, because we could improve the precision, the diagnosis, and we can anticipate. Another, and the final issue, this is my final slide. And there are several applications of biomarkers of effect in clinics. But one very interesting is the idea, I present you two possible applications. One is as a surrogate endpoint. That is, in the clinical trials, there is a big competition. There is a big competition because everybody wants to have the results as soon as possible. So there is really a need for speed, like in the video game. The sooner you get results from your clinical trials, the sooner you can put your new drug in the market, or people with the disease can use the new market. So there is really a competition to do that. There are new study design, like adaptive studies, in which you anticipate the result of the clinical trials. But there is another really important issue, which is the use of biomarkers as surrogate. And nowadays, I make an example, like colon cancer. Polyps can be an intermediate surrogate biomarker of cancer, colon cancer. The idea, if you get the drug that reduces the frequency of polyps, you have also an effect on colon cancer. That would be great. Unfortunately, we don't have this kind of surrogate biomarkers validated so far, but there is a lot of research on that, because obviously that would be really great for research, for companies and for patients as well. Another important issue is called in the clinical studies enrichment strategy, in which you identify people at higher risk for the disease, and you treat them. You treat them more earlier, or you decide, identify specific strategies, therapeutic strategies for them. So this procedure of enrichment can be done easily, much more easily with biomarkers of effect. Think about the studies on chromosomal aberrations, micronuclei, even DNA damage on the comet, linking to cancer these events. So you can identify a group of people which have a higher risk of cancer. And once we have a valid strategies for preventing cancer, or you want to apply more intense preventive strategies in a group, we can identify this group thanks to biomarkers of effect. So you see that thank you very much for that. I finished the screen sharing, and I wanted to say that actually I'm really enthusiastic about effect biomarkers, because there is a great potential in that. And I believe that the use of complex approaches like systems medicine, you saw systems toxicology, that is to put together several pathways, several exposure, diseases, genetic profiling. And for clinics, the possible use of biomarkers of effect in clinics really is a challenge that it will be the real challenge in the next few years. So thank you for your attention.
Thank you, Stefano, very much. I really miss clapping in this virtual setting.
You can clap anyway.
Yes, for me. So I'm sure that we have some time for several questions. If you're available a little bit longer, so you can raise your hand, you can just turn on your microphone and ask, or you can write a question directly in the chat. So
I see two people.
you see already two people, yes.
Sanin.
Okay, Sanin, could you please turn on your microphone?
Jada before. No, they were just not making question. Just playing with the screen.
I would say those were applauds for the.
Okay.
You missed clapping, so there was a couple of emoticons of
They
clapping.
were joining. They were joining clapping.
Yeah,
Okay.
we are now super modern with.
Okay. They can also write you can also, if you prefer, you can write question on the chat.
Okay, while we're waiting, I mean, I was always curious. I mean, I can go with the question. I was always curious when you get the result individual of a micronuclei analysis, and you get unusually high number of micronuclei. What can we say to that particular person? How to interpret these results?
That's a very difficult question. I would say, first, it depends upon the reason for screening that people. Because if the people was screened for a particular exposure, maybe that is oversensitive to this exposure. So I would do some more investigation about the way how is exposed and whatever. If you did it for maybe diet or whatever, I do the same. If you do it under a clinical purpose, I would do maybe because we have, I don't know, obese people or people with diabetes. I would make a more intense evaluation of the risk factor for these people, and possibly I establish a clinical strategy. I mean, like more closer clinical investigation. Instead of every year, you come every other 6 months or every other month. However, this is exactly what I believe, because from the regulatory point of view, from the practical point of view, there is no such a rule, neither for occupational exposure or environmental exposure, neither for disease anticipation.
Yeah, thank you.
Any more questions? I'm not seeing any, but as Professor said, he will stay with us for a couple more minutes at least. So if you come up with something, just be free to write it in the chat. In the meanwhile, we can continue with our next speaker, and Marco will introduce her.
Yeah, thank you, Anya. So yeah, we are moving on with the program, and our next speaker is Aida Kulo-Česić, and she's a medical doctor with a clinical pharmacology and toxicology background. Currently, she's working as a full professor at the Faculty of Medicine, University of Sarajevo, and her doctoral research related to perinatal pharmacology and of paracetamol and other drugs, and was conducted under supervision of professors at the Catholic University of Leuven in Belgium. She published more than 70 research articles, and since 2021, she's a full member of European Academy of Science and Art. And now I would like to invite Aida to give you your presentation.
Thank you, Marco, for your introduction. I'm going to share my screen. So just let me know when you see the full slides.
Yeah, it's okay.
Okay, great. So as Marco already said, I'm very happy to have this drug again on my board of the investigation. So I did this doctoral thesis in Leuven 12 years ago, and at that point we studied the pharmacokinetics of paracetamol in this very vulnerable populations of pregnant women, and the same women during the delivery and also in the postpartum period. And now what I'm going to do in this presentation is to mainly share new data that we have meanwhile about the paracetamol. For me as a pharmacologist and also for other clinicians, nothing new about that. So we all know that after the preclinical and clinical testings of drugs, we got the drug in the market. And then once the drug is exposed to many patients, then we see some rare side effects and signals that we need to react upon. In this case, it's a bit strange that after so many decades of, let's say, safely use of paracetamol, now we are getting signals that we need to take into account and to measure to see if these signals are really true and if they are of clinical relevance, which is the most important thing for us. So the presentation is going to have several parts. So I'm going to present the general pharmacokinetics and pharmacodynamics facts, some safety concerns that we already are aware of in animals and also in humans, the specificities that we have in those vulnerable populations that we are mainly focused regarding the paracetamol. Then there are some current scientific statements and counter statements. So there is a kind of scientific discussion online on board. And what also is going to be discussed in this presentation is the methodological drawbacks of the available observational studies, possible clinical consequences. What are then the current recommendations that are issued by the regulatories all over the world, and what are perspectives and barriers in all these future studies. So we all know that paracetamol is a very well-known drug, and there are several names for paracetamol. It's called acetaminophen or P-acetyl-P-aminophenol, which is then can be used shortly APAP. So we know all that it's used for the analgesia, for antiparesis, and also for the promotion of closure ductus arteriosus in small children. So it's been for years announced as the safest drug option for the pregnant women and for the children. So what we know about the pharmacodynamics of the paracetamol, we are all aware of its active metabolite, which is formed in both liver and the central nervous system once the drug is taken. And then this active metabolite, which is called N-arachidonyl phenylamine, is the one that is responsible for the effects of the paracetamol. What is not new is that it's inhibiting the COX activity. That way it prevents prostaglandin synthesis and decrease the pain and the fever. But this active metabolite is also active on other sites. For example, at vanilloid receptor 1, and very interestingly, also it has the low affinity for the cannabinoid receptor 1. And this is, in fact, the mechanism of action, which is mainly the focus of these new toxicology signals that we are facing, because it's been shown that cannabinoid system has been involved in the normal neurodevelopment in humans and also in the animals, and this active metabolite of paracetamol seems to have disruptive effects in this pathway. It's also affecting descending serotonergic pathways and also some potassium and calcium channels included in the nitric oxide synthesis. So this is what we know so far. This is multidirectional mechanism of action that can then affect multiple organ systems in our body. So except for that active metabolite that is in fact doing all these things for the paracetamol, we also know that the paracetamol is been metabolized, that the inactive metabolites, mainly glucuronide and sulfate, and those two substances are going into the urine to be excreted out of the body. It's only 2% of the paracetamol that stays unchanged in the circulation, and up to 10% of paracetamol is metabolized into the toxic substance, which is for years known for us. It's an N-acetylbenzoquinonimine, and this substance is, the amounts of this substance secreted are normally neutralized by our glutathione. Only in cases we are very susceptible, or in cases of overdose of paracetamol, we may run off the levels of glutathione, which can lead us to the real toxic effects of these substances, carrying out the central lobular necrosis and the liver insufficiency. So this is what we know so far about the paracetamol pharmacokinetics and pharmacodynamics. Let me just see. Okay. So the thing is that in the last 10 to 15 years, we are getting new data about the paracetamol. And the thing is that the most vulnerable populations that we have been treated by paracetamol, pregnant women and pediatric population. In fact, those two populations are really surrounded by ethical and legal issues. That's why they are orphaned from the drug studies. We have a lack of pharmacokinetics as well as pharmacodynamics data, which takes us to the off-label use and poor clinical care. So the problem is that there is an increasing number of pregnant women who are taking paracetamol. It's up to 70% of pregnant women who at least once take the paracetamol during the pregnancy, and majority of them is taking it during the first trimester, that we know that it's more critical for the embryogenesis and organogenesis. And also in the pediatric population, more than 90% of children has been exposed to paracetamol. And it's also increasingly used off-label in the neonatal intensive care units, with the increase of the number of patients involved in this treatment. It was the 15th most common used medication just 13 years ago, and then 10 years later, it was the third most frequently administered drug. So the problem is that it's prescribed to extremely preterm neonates. So what do we have again? So just to summarize the safety concerns, so we have a problematic exposure during the pregnancy, as we know that the paracetamol is crossing the placenta very rapidly, and the transfer is far faster from the maternal to fetal side than the other way around, and the paracetamol is transferred up to 50% of the original dose to the fetus. And the other thing is that we have pharmacokinetics specificities in both pregnant women, breastfeeding women, and young children. And there is also, as I have said already, multiple mechanism of action that can affect multiple organ systems. So this is the slide, only is the schematic, very simple presentation of what we have found about the pharmacokinetics of paracetamol. So once the clearance of the drug has been corrected for the body surface area, and if you take into account that this dash red line is in fact the level of paracetamol clearance before the pregnancy, so in pre-pregnancy state, then we saw that women at delivery are really capable of excreting the paracetamol at the delivery time. So it means that our body at the delivery time is really safe of the substances, including the paracetamol. But then what we realize as a problem is a decrease in clearance possibilities and abilities of our body once we are in postpartum breastfeeding period. These are the measures at the 3 months after delivery, again at the 5 months after delivery, and 12 months after delivery. And at all these time points, we have seen clearance data that are still not reaching the pre-pregnancy states. That was really something that frightened us. So it means that delivery is not a problem. Pregnancy also, we are capable of excreting, but then in postpartum, we are losing that ability to excrete paracetamol. Still, it seems that paracetamol is not that dangerous in adults and not that dangerous for the mothers, as it is dangerous for the small infants, especially because there is a pharmacokinetics problems with the small infants. They are immature, there is immature kidney function and also metabolism in the liver, and that's why we have drug half-life much longer in the neonates compared to the older children and in adults. That's why we need to do dose reductions. These are the reductions that we need to do. These are based on the physiology-based pharmacokinetic simulations, where we note that those for the neonates, so our children that are up to 28 days of age, we need to decrease the dose up to 50%, and in those older up to 33% of the regular dose that is taken normally in children older than 2 years. So we also saw that there is enhanced sulfation and glutathione production in neonates. The other thing is that we all want to see what are the results of the preclinical testings, and the data in animals are really exhaustive. What we know so far is that during the early phases of animal pregnancy, we can see degenerative and necrotic changes in central nervous system, in the lungs, and in reproductive systems. It's also that we see the disruptive ossification and liver and kidney necrosis in both mothers and the fetuses. Once the small animals are born, then we still see the neurodevelopmental issues, but this is something that we expect, as we know that the first day of life of the human neonate is corresponding to the 11th day of life of a small rat, let's say. So the cognitive development seems to be very, very sensitive to the exposure during the early development. So the first study in children that really raised the red flag was published in 2008. And it was a relatively small case control survey-based study. It was only that idea that maybe vaccines are involved in the autism spectrum disorders and ADHD. And then people said, some scientists said, okay, what else is being taken with the vaccines together? And then they realized that some pediatricians are extensively prescribing paracetamol to relieve of the pain, or at least to prevent the pain and the fever that might be induced by the vaccine. So they found a significantly associated paracetamol with autistic disorders in those children that were younger than 5 years. And this is really what raised the red flag for the preventive usage of paracetamol during vaccination. We still have that in power, and we still need to really advise for not taking paracetamol with the vaccination, just for the preventive care. So I searched through the literature, and I found a nice review that really merged all the studies that we have now about the paracetamol exposition during the pregnancy and also after the delivery in humans, so in small children. And there are 3 major toxic signals that are emerging in the literature. So it's neurodevelopmental adverse effects. These are atopic adverse effects, as well as reproductive adverse effects. For the neurodevelopmental adverse effects, there are 13 observational studies. One of them is ecological one that are reporting the association with paracetamol use. And the possible mechanism is, in fact, that I already mentioned, the active metabolite, that it has the disruptive effects of the cannabinoid receptors ones. The other thing is the atopic adverse event, and the association has been found in all of 11 observational studies with the possible mechanism of increased oxidant-induced inflammation and T helper type 2 pathways. What we have seen also regarding the atopic risks is there were some data in the literature that late gestational paracetamol exposure can lead to asthma and wheezing in the offspring. And then that was ruled out by the meta-analysis done that where respiratory infection was in fact one that was identified as the cause for the asthma and wheezing rather than the paracetamol itself. So the reproductive adverse effect, they were described in the 4 cohort studies, and it was confirmed in 3 of those with a shorter anogenital distance, hypospadial cryptorchizism in male offspring, and also early female puberty. The possible mechanism was in fact the androgen disruption and the disruption of steroidogenesis. There is a mini review published just a year ago that said that there is no enough evidence for the clinically significant effects in humans, that the conclusions can only be seen as limited and inconclusive. So that was for the prenatal exposure. So exposition of the mothers and then transfer of the paracetamol to the fetuses. This is what we have seen so far. In this slide, we can see what is the summary of the results of postnatal studies, of the neonatal studies. And there are 3 studies examined in this review, with the 1 study reported the association, and it was in fact an ecological study that showed a strong correlation between the autism and paracetamol used with the circumcision. And then there are 2 randomized controlled trials that really compared paracetamol versus placebo or paracetamol versus ibuprofen for the PDA closure, and none of those really reported significant difference in neurodevelopment and topic issues. So there is a lack of evidence for these studies. We can see it clearly. There is also another interesting approach that I found in the literature. It's the study that's been undertaken to see why paracetamol was widely believed to be safe for use during early development, and what was this positive claims about the paracetamol was based on. And then after the critical review of those papers who did this claim, they found 280 papers out of more than 1,000 papers published on the paracetamol itself, and only 52 of those studies are were in fact reporting the experimental studies, and they said that paracetamol is safe, but the median follow-up time was only 48 hours. None of these trials really studied neurodevelopmental aspects of the paracetamol use. So the conclusion of the authors was that the safety of paracetamol was not carefully considered, and it was taken for granted. As a result of all these preclinical studies, we now can see that paracetamol, in fact, during the preclinical testings showed the long-term side effects, both the neurodevelopmental and others, that would take the paracetamol, in fact, in the position that it wouldn't come into the phase 1 testing in humans ever. And it would probably never been approved for the use in children if we had all this information before it came into such a wide use. So the clinicians said, again, based on all these observational studies and all these signals, there was a consensus statement published in 2021, and it was signed by almost 100 scientists, clinicians, and epidemiologists who called for the precautionary action when it comes to the paracetamol therapy. And they said that there is a consistent signal that we cannot ignore, because there is a signal coming from toxicological, mechanistic, and also epidemiological research. So that is something that really called for the cautionary use of paracetamol, but soon after that, just in the next issue of the same journal, it was Nature, I think, yes, the reaction was the consensus counter statements, where the other group of clinicians, scientists, and especially teratology specialists called for the caution over causal interference from the available observational data. And also there is another paper with the same purpose. And this is something that is really expected and can be understood, since we really at the time don't have more safe option and don't have the more safe substitute for the paracetamol. So what they called in this counter statement is that the methodological problems of the studies that's been performed in the paracetamol toxicology field. So it's we all know that these methodological inherent methodological problems with observational studies includes primarily no ability to establish cause-effect relationship. There is a problem with diagnostic accuracy for the outcomes that they measured. There is also unvalidated outcome measurements. So those questionnaires were really retrospective self-reporting studies that are filled with usually parents, and those questionnaires were neither developed nor validated for the purpose they used. There is also a failure to account for confounding, for example, mainly the confounding by indication, when majority of pregnant women who use the paracetamol, they use it to treat a migraine or fever. And both of these, migraine and fever, were associated with adverse effects on fetal neurological development. So we cannot rule out that this is only the effect of the disease itself. But also there are some shared comorbidities. There are hereditary aspects of the neurodevelopment and psychiatric disorders. We also know for this thing that the longer the use of paracetamol, there is during the pregnancy, the higher the risk of the mother to have some mental disease, and they use antidepressants, which can also then be another confounding that need to be taken into account. There is also a problem of different exposure and misclassification used throughout the studies involved in all these conclusions. So also what's been said, it's the confusion with other analgesic drugs that's been used by pregnant women that could lead to the overestimation of the true effects of the paracetamol. So as a clinician and as a clinical pharmacologist, I need to say that there is really, that we need to take all these data with caution, because this can have some clinical consequences. As I have said, we have no better option than paracetamol at the moment. It can promote, all these things can promote uncertainty, fear, and guilt among pregnant women that can make them hesitate the medication. So it means that we can end up with untreated febrile illnesses, and then the risk of the febrile illnesses being untreated can be even higher than the risk of the exposure to the paracetamol. And also, we have already seen that the pregnant women are using other NSAIDs, non-steroidal anti-inflammatory drugs, which are not safe for the pregnancy. And with this kind of statements for paracetamol, we can in fact cause even more taking of the other NSAIDs. So for this, with all this reason, it's totally understanding that current recommendations FDA pregnancy category, they announced that there are animal studies showing adverse effects at clinically relevant doses, but they still claim that in humans, there is no clear association with the birth defects, miscarriages, or adverse maternal or fetal outcomes, that the data from the epidemiological studies need to be extrapolated with caution because of the biases that we mentioned, and also any associations seen in clinical cohort studies need to be clarified by randomized controlled trials, which are very tricky in this period. I'm going to give you some barriers for this. So American College of Obstetricians and Gynecologists also announced unchanged clinical guidance, and also American Academy stands with the same compatible use of paracetamol with breastfeeding. So what we need in the moment, it's immediate need for the more robust data from the more rigorous methodologies, so we can continue extrapolating data from the toxicological investigation and mechanistic studies. But we need also more human data in larger epidemiological studies with optimized design, with larger clinical trials. Even better if it can be randomized controlled trials with precisely defined indication, dosage, and duration, and also with a long period of follow-up. I would follow up it until the adulthood, because we have the information that the neurodevelopment in fact takes time until the adulthood. What are the barriers in obtaining those reliable prospective control studies? There is a great historical hesitation because of the ethical issues. It's not easy to do the clinical trials during the pregnancy. There is a problem with parenteral consent. You need to get the parenteral consent, and the major issue with this is the sampling techniques, venipuncture of those small children, the small volume samples that we can take from these venipunctures, and also the issue of the repeated sampling. Although there are some approaches that maybe blood does not have to be taken, saliva can be taken also. There is also a large number of patients needed, problem with establishing controls, long duration of the study from the conception until the adulthood, as well as the problem with formulations. At the moment, we have some formulations of paracetamol that also include the antidote of paracetamol and acetylcysteine in order to decrease possibility of the toxicological effects. But what we have seen so far in laboratory animals, that exposure in the postpartum period to this currently approved levels of the antidote with paracetamol can cause dramatic increases in social behavior in the later life of the animal. So additional papers are appearing, further focusing on the toxicity of paracetamol. It's now also involved, the DNA damage can be the cause, and also microcirculatory dysfunction, also next to the oxidative stress and drug metabolism issues. What we can see now, besides these high doses toxicity that we expect some kind of that, some studies have shown that low doses of paracetamol are also can have a protective effect on the ischemic and amyloid lesions. In that, and because of this hypothesis, the research group at my laboratory, we are now setting up a small animal study where we are going to see if this last hypothesis is true. So we are going to set up a small study in neonates, in the neonatal rats, 11 days old. We are going to expose them to intermittent asphyxia to induce the ischemic lesions, and then for these rats, they will be exposed to the preventive or also the therapeutic doses of paracetamol, and we are going to follow them up to 6 months to see if there is some development of toxicology signals or something like that. So what we can do meanwhile to keep our community happy, not in pain and not in fever, we need to proclaim that the caution should be taken with treating pregnant women and the children in with paracetamol. We need to take into account the risk of untreated febrile diseases, and even though the drug should be taken in low dose with the shortest possible time, but what we can definitely claim is that no treatment is needed for mild fevers. For the fever that are lower than 38.5 centigrade degrees, do not require treatment, and definitely not the prophylactic use of paracetamol with vaccination. What we know from the historical data is that the pain has been undertreated in children, especially in those who cannot speak. And in contrast, the fever is in fact overtreated, especially in the high-income countries. So let us then really consider not treating the fever, which is not higher than 38.5. So thank you for your attention. That was what I prepared for this speak.
Thanks a lot, particularly with these last few slides that calm the situation a little bit. Do we have some questions from the audience? I mean, it was a really interesting topic, a really relevant one. And I can see a lot of toxicologists in the participants list. Okay, while we're waiting, I mean, you can also type in the chat or just turn on the mic and so on. But while we're waiting, usually the treatment for high fever is paracetamol or ibuprofen. I mean, or a combination one or two. Since we are now talking about toxic effects of paracetamol, do we know a little bit more about ibuprofen that is like alternative?
Well, ibuprofen as a non-steroidal anti-inflammatory drug should not be taken during the pregnancy, not through the older trimester, since it can bring some miscarriages and some side effects to the fetus, but it can also affect many of the organs into the fetus. So this is what we are fearing of that ibuprofen is going to be taken more because of this story about the paracetamol. So it's only that we can do is just to give this advice: take the drug only if you need it, and if the pain is unbearable, and then you take it in low doses. Or what has been also suggested to the pregnant women, to try to rest a bit, to try with some other substances that can have pain relief effects and so on. So the focus, I would say, it's not that we really frighten the people, but we still need more data and time to see really if all these data are of clinical relevance.
I would also like to use the opportunity to thank Aida for joining us, for coming into this, our small community.
Well, thank you.
Yes. So great talk, of course, and all questions I had, you already answered them, like Marco asked you about alternatives, or I was kind of worried when you said that nowadays paracetamol wouldn't even enter the clinical studies. So I wonder what we will be taking, but definitely we need more studies and this even explains why we need to cooperate with medical doctors, toxicologists, and I'm of course happy that you mentioned DNA damage. So we also need to...
Maybe regarding the Professor Stefano speech, maybe we can also try to figure out some biomarkers that can be measured in those population exposed to paracetamol. Yeah.
Great, thank you. And Professor Bonassi excused himself privately. He had some private issues, so he had to leave. But I think we have 2 or even 3 questions in Q&A and chat sessions. So Marco, could you please?
So I can see those questions. At which age of children is the clearance the same as in adults? It's been generally, we think that with the age of 6 months, the children are reaching the same level of clearance of the drugs as seen in adults.
And one question in Q&A, can you see it? Which polymorphisms are known to be more involved in paracetamol metabolism?
I don't know for the polymorphism, but what I know is that the oxidative metabolites are in fact the enzymes that are involved in the oxidative metabolites are those that are known to be involved in the toxicology.
Great, thank you.
Okay, maybe anybody else? Okay, if not, I think if you remember or think of a question, I'm sure that you can write to our lecturers and to make more questions. If you don't have contacts, you can also contact us. We can then provide the contacts back and make this initial communication.